Hi, folks, and welcome to this episode of the EMS Today Show. I'm AJ Heitman, and pleased to have with me today Asbel Montes, who is the Senior Vice President of Strategic Initiatives and Innovation at Acadian Ambulance. I think I have to give him a good bio intro because you have to understand how deep our conversation is going to go. So bear with me, Asbel. You began your career in 1999. Included directing and leading teams that provided revenue cycle consultation to the air and ground ambulance agencies. And I think you're going to see a theme here about Asbel's expertise. And when we talk about reimbursement and finances, that's the reason that he's on the show. And culminated into his position of Vice President of Government Relations and Revenue Cycle at Acadian Ambulance Service, because he gets it, he understands what the government's thinking is and where we're going with all of these things. His new title of Strategic Initiatives and Innovations came in 2019, and then all of a sudden now we have the pandemic. So your title after the pandemic might be Pandemic Recovery Expert, because that's really where we're going. He's been a member of numerous organizations, the AAA, National EMS Managers Association, and certainly NAEMT. So knows the group, knows everybody that we're dealing with, has been appointed to all kinds of government committees. I think this interesting one here is to the Department of Transportation, assigned Asbel as a member of the Ambulance and Patient Billing Advisory Committee. Once again, there's that federal link, which I think is important. Much respected thought leader, was asked to testify as an expert witness before federal and state health committees, and has been a contributing author for GEMS, EMS World, many other people. So we're pleased to have you with us, Asbel, and welcome to what I call the EMS Today Show. How you doing?
I'm good. Tired, but good.
Trying times.
It is. It is a game changer for EMS. Good and bad for some, depending upon how you're looking at it.
Yeah, and as we've discussed in the past, a lot of things happened over the past couple of weeks. A lot of things were loosened up. A lot of telehealth has been okayed. Other relationships established with hospitals. And what I've been saying to everybody, and you can disagree with me, we ain't never going back, because the floodgates have been open now. CMS and other people see what they had to do to keep the system working, and they're going to probably keep some of those things in effect. Do you agree?
I absolutely agree. And to your point, we're never going back. It's exactly what I've been talking to a lot of my colleagues about as well. It's almost like it is a pilot program on steroids. We are in real time piloting innovation that has been sporadic across the country. It is now happening in real time throughout many of our communities. And unfortunately, the funding aspect has not kept up with the innovation. And that is, I believe, where we are. It's the crossroads where we are. And so it's playing out in real time. We're getting some good outcomes on some of it. On some of it, it does need some thought process. And so too fast, I was talking to an HHS leader last week, and basically they were talking to the tranche funding, but they made a great analogy that resonates with what we're talking about right now. AJ, is with speed comes lack of precision. And so some of this stuff is happening so fast, it's not as precise. So we do need as an industry to concentrate around that and make sure that as we work through these numerous waivers that are happening, because you mentioned telehealth, absolutely, that is the game changer for our industry, treating in place. But how does that nuance look to make sure we're delivering the quadruple aim is key and imperative. You can't just say, let's do this without certain types of parameters put into place to make sure we're continuing to deliver the right care at the right cost at the right time.
Well, let's go back to some basic givens. A couple of givens is that call volume has been down for everybody. Interfacility transfers for many have dried up to the point of layoffs. Hospitals have been holding on to their patients, and the general public has not been calling EMS. The public right now is afraid to go to the ER, that they're going to catch it. And a lot of people have stayed away from the ER. Now, I just saw today that New York's call volume is lowering down. In New York, in the hotbeds, more people have been calling than probably need to. As we start to see the drop, I mean, they had a 400% increase in the number of cardiac arrests, 200% increase in the number of strokes. And I think that we're going to still see an uptick in mental health calls after this is over, because there are people that are losing everything that they own. No matter how much money we've tried to throw at them, the government has not been able to throw the right darts in the right places. I still believe, and I'll let you carry it on, that EMS has really gotten a lot of scraps from this whole thing. We've gotten a lot of praise, which is good for us, and the community loves us. They see us running around the streets, but PPE is not going to be the issue after this is over. We're still going to have ambulances. The big companies have not been able to purchase their normal number of ambulances and ambulance vehicles during this whole thing. So we're going to be in, my prediction is a 2-year lag where we have to find ourselves. But tell me some of the things that you've seen happen with CARES and with the ambulance industry.
So boy, you have gone through a lot of information here. So I'm going to try to peel the onion back.
Peel it.
Of course, with it being reimbursement, my background, especially as we deal with policy, most of us know that the majority of our funding is federal and state dollars. Hence the reason why we have to be very, very connected with what's happening on the policy. And we technically really have gotten the scraps of the stimulus funds from the CARES Act. I was just on a call earlier, and really the number, guys, is less than 0.5% of the $50 billion in that first tranche of funding that went out in the $100 billion Public Health and Social Services Emergency Fund. Let me say that number again: 0.5%. Less than $500 million has gone to the ambulance services of that $50 billion that they just sent out in general allocation. The second thing that they did was they allocated the $10 billion to the hotspot zones, but EMS was not in there. Another $10 billion to the rural communities, EMS was not in there. There's another $29.6 billion they're trying to get out, and it's to the uninsured right now and to those that are Medicaid-only providers, which is not EMS. And the uninsured is for presumptive COVID and positive COVID, of which we do very, very little of when you look at the numbers compounded to everything that we're doing in the uninsured space. And we are one of just very few providers that have any uncompensated care funding, AJ. Very rare. Hospitals have gotten the lion's share of all of this money, and I'm not negating the importance of having the hospitals on the front line, but what are all the articles that we're seeing now if it wasn't for our EMTs and paramedics and our ambulance services and whether you are governmental, whether you are for-profit, whether you are nonprofit, now's not the time to worry about that. What the time is to say is, I get it, it sounds great, but my one thing is, it's all talking, it's all lip service to me right now. Unless we see you put your money where your mouth is to make sure you protect the infrastructure of pre-hospital care, to be honest with you, I like it. It looks great. But if it does not turn into, and we have a fiscal cliff, and we've got, especially in some of the southern regions, as hurricane season comes up and you've got emergency preparedness beginning to happen on June the 1st, and in other areas of our country that we're looking at that, we rely on the 911 and on the pre-hospital care infrastructure, whether you're emergency or non-emergency, to help respond at this point in time. You've got me on a talking point here because I love it that we're being recognized. They're finally saying EMS. You know, our speaker Pelosi, I've got to give her a shout out for actually identifying EMS when she was talking on some of the Today shows. That was a long time coming.
Yeah.
to make sure that happens. So great advocacy work is happening, but to me, it's just all lip service right now, unless we really see specific appropriations going to the EMS industry to make sure the infrastructure does not collapse.
Well, let me give you a couple of loaded things. First of all, we really don't have a lead agency in EMS. There's nobody really advocating for us. A lot of people try and advocate for us, but I'm going to say something. I believe that Congress believes that EMS is well funded by their municipalities. I think that's the very first misconception. They don't know that we're still doing, in some cases, bake sales, that we're some cases doing subscriptions. In some cases, the municipalities give us squat. They don't know that. They don't know that we didn't have a stockpile because nobody would allow us the funding for a stockpile. I mean, we didn't even have tourniquets a couple of years ago, and the government gave us nothing in there. So, you know, some of the very poor services, particularly the rural services, the Indian tribe services, they don't have access to replace ambulance vehicles. So I think that that's the misconception. I don't know how to crack that nut, but you can tell me if I'm wrong, but I think that they feel that we're already well funded.
So I do think that with the way, if you kind of look at the structures of the stimulus package and the money as they are sending it to states and local governments and to the Indian tribes or what have you, I do believe, and I will tell you just in conversations that we've had with our legislators as well as on the Hill, a lot of them think that the access of the funding can come through, especially if you're a governmental entity, can come through either the grants that are going through the community development grants, whether it's going to go directly to the state or directly to your local jurisdiction. What they don't know is what you just talked about right there, is the cities keep those money, and it depends upon the relevancy, or they feel the relevancy of that area, depending upon how much money that they get in that area. And then if you talk about the nonprofits and the for-profit companies that may be contracted to do 911 work, you've got a whole other element that you're dealing with there. For instance, such as the company that I work for. As an employee-owned company, that we're a private company, the funding is not even as direct as that component would be. And so I do think there probably is advocacy work as we're continuing to work at. You are seeing the piece that says there needs to be a specific appropriation for that, or a specific clarity within the next CARES package that says a portion of the funding that we give to state and local government needs to be designated for and actually list emergency medical services. And kind of indicate either whether it's 10% of that funding, very similar to how they indicated in that last 3.5, where they did the $100 billion. They said we're going to replenish the general fund with 75, but 25 billion of that is going to have to go to handle testing and whatever. So Congress has shown that they can do it. It's just the industry needs to be loud to say, you absolutely need to specify exactly what needs to go to EMS. Because if we don't do that, it's going to be left up to generalities, and we're just going to continue to get just pennies on the dollar.
So how do we do that? I mean, the fire service has said they need $50 million or whatever it happens to be. And how do we as a unified, we don't have a unified voice. There's no way we don't have a unified voice.
Yeah, and you know what, that unfortunately is the predicament. And so we do have a few national associations that are out there between the International Association of Fire Chiefs, IFF, National Association of EMTs, and the American Ambulance Association, as well as there is there's an alphabet soup of tons of other associations as well. You, as well as I do, know that I'm very active with the American Ambulance Association, which predominantly represents private EMS, some public utility models, nonprofits as well. But everything that we're asking for right now actually helps everyone. Like they say, the rising tide lifts all the boats at this point in time. The issue is when you start talking about funding, then everybody is wanting to access that piece of it. And there is different funding avenues dependent upon if you're a governmental agency or you're a nonprofit private EMS agency. So there is different ways to get at the funding that needs to be creative. So in my opinion, it's not like if the governmentals are saying, you know what, give us a specific appropriation into a community development grant or a block grant there, or funds going directly through the safer grant. That is okay. It's just saying that if you're nonprofit for profit, then your funding stream may need to go this way. So I don't really take that as the industry is not aligned. There is just different avenues to get to the same result. It's just like you have different interstates that may be able to get you to the same location, or state road. Some people may go this way. It may take them, 45 minutes to get there. Some may go an hour and a half around, but they get to the same point. So I don't really take that as we don't have. It's just if we would have a concerted effort, and I think that's what's lacking, get on the same sheet of music to say the industry needs funding. It needs it in these buckets. This is the easiest way to go at it. That is where I think there needs to be a concerted effort. And to be honest with you, I'm just not sure sometimes we are there to think things outside of like taking our own way that we see things through different lenses, AJ. I'm trying to be a little political about this right now. But I do think that sometimes we just need to check our egos at the door, get into a room, figure out what's best for everyone as the whole. But sometimes, unfortunately, that does not always occur.
I've had a lot of calls and a lot of private discussions with a lot of people who are saying, so what are you saying? What do you think we should do? And I said, the first thing I believe is that everybody should be documenting everything, every penny that you're spending, every dollar, everything you've lost, every person who called off sick, all those things. And every service in America should do an after action after this is over. And then county associations and state associations and regional should all come together, AAA, NAMT, to put out a position paper, because they may say, well, PPE. Well, PPE to the hospitals is different than PPE to the ambulance services, because a nurse signs on shift and puts on PPE and handles maybe the same patient for 7 hours, 6 hours, 3 hours, but EMS goes on call after call after call and takes off the PPE, puts the PPE back on. So 10, 12 shifts in a call, or 10, 12 calls in a shift means a lot more PPE. So our numbers, people have to understand. They've never understood our industry, and now for sure they don't understand our industry. So let's go into something else though. Let's go into the fact that I have not gone to a doctor's office in the last 8 weeks. I have had even my eye doctor call me to do a virtual eye exam, believe that or not. And you know what? I like it. And if I have my way, I'm not going back to the old way. And I think that you and I have had that discussion. I think it's here to stay, right?
Yep. Telehealth, the infamous telehealth. And those of us that have been in the forefront, kind of waiting to see this happen, those that participated are actually, it was interesting with the emergency triage transport model, the ET3 model.
Right.
Like literally the application process came out a few days, or the individuals, the applicants came out right before the PHE. And that has kind of turned that on its head. You've seen waivers happen where we can now take patients to alternative destinations. And then you've got the telehealth waivers, numerous waivers happening right now. And EMS can actually be involved with that right now. If you've worked with your local states on doing some different ways of doing things, and we have a waiver going on in Louisiana right now that we will go live on May the 15th in a very nuanced approach to this that we made it through CMS approval on. But this is a game changer for the industry. I'm not saying that it is something that I was having this conversation yesterday with an individual. I'm not saying that the model in Louisiana is what I would have said was the best model. But it's the difference between a realistic approach, AJ, and idealism. Idealism says in a perfect world, this is how you should do it. We're a protocol driven industry already. Why does medical doctors need to be so coordinated in the effort of that? The reality of the fact is there is an affinity to make sure that there is always medical direction somewhere. The issue that we've had as a company as well is to make sure, because we're already having workforce shortage issues, is allowing our paramedics and EMTs to be physician extender, but through an ambulance agency, AJ. Does that make sense?
Yes.
And so as telehealth comes through, so you don't lose your workforce, you're providing an avenue for your frontline team to do more than just do transfers, but also under the auspices of a physician as well, whether you contract with them, whether you employ them. But telehealth has changed the game. And the CMS administrator currently, as well as the HHS secretary, has gone on the record several times already, indicating that there seems to be an affinity by CMS to make these waivers permanent. And so I would anticipate, if I was the ambulance industry right now, this is your new norm. So you can either stick your head in the sand and hope that norm goes away after the PHE and think you're going to go back to business as usual, or you can say, you know what, if you think Americans who have been doing this telehealth demonstration pilot for the last 2 months is going to agree again to go sit in a doctor's office waiting room for an hour, I have swampland in Kansas to sell you.
Yeah.
You know what I'm saying, AJ? That is not going to happen.
Well, tell me can you reveal what your model's going to be on the 15th?
So what we're looking at really through the process is that the ambulance agency can bill for the treatment in place. It's outside of what's being advocated under an AO 998 code, you know, as right. What individuals said. It's really following some very similar premises of the ET3 model, but under the auspices that your medical director has to be licensed or has to be a qualified practitioner with Medicare, Medicaid, as well as under the insurance health plans, registered as well. So that piece would fall under technically like a physician fee schedule, but it allow the ambulance service to do all the billing. To where it's not like you have to contract with a physician group, because our concern has always been that there's mediators that come in here or intermediaries, and that always exacerbates the cost of healthcare. So truly, if we're trying to hit the quadruple aim, we're trying to reduce the cost of care as well. We already know that ambulance services have 24/7 frontline responders that technically should be physician extenders, but the issue has always been, what's their oversight? How do we know their medical directors are qualified to work within a certain health plan outside of just taking your state's licensure for that? And there's been concerns regarding that. So that was the realistic approach, was to say, is there a way that we can kind of meet in the middle here during this public health emergency, work with the state on all the waivers? And that was subsequently what was approved by CMS under a state plan amendment change as it dealt with that. Whatever. So we're operationalizing it. We're the type of company that kind of rolls things out as well. But this is a game changer for the industry. And so I know we're having some challenges on the treatment in place, getting that done federally. I think we'll be successful on that. I just am concerned that it's not just for the PHE stint and then it goes away.
Yeah.
If we don't have certain parameters in place, AJ, that's what concerns me on the treatment in place national initiative, is that if we don't have certain fail-safes that ET3 put in it, then that could be a concern. So what I am very comfortable with is to say, for the PHE, let's do AO 998. However, you're going to have parameters. So maybe we need to focus the ET3 on a quality-based initiative. So CMMI needs to come back and say, let's introduce now quality. So we're already demonstrating we can do treatment in place. We're already demonstrating that telehealth is something. Quality is the next thing. The quality payments are the next thing, AJ. So why don't we have CMMI focus on quality demonstrations? Because ET3 has really been, I mean, it has been jettisoned through the cannon.
I call it ET4 because the other T that I've added is anything's on the table.
Yeah.
That's my other T.
And I like that. ET4, making that quality. Yeah. ET3 is going to be, there's going to be a quasi 3. I personally do not see ET3 happening just because of all these waivers and what we've demonstrated. I think it's going to be something more, and I'm going to use your acronym that you just gave, like an ET4, but a quality-based piece. And that would be my suggestion, that CMMI really begin to focus how to move our industry into quality-based payments.
During the pandemic, have you seen services that have been able to divert patients to urgent care centers?
Yes, in some of the areas that we operate in, that is happening already. But technically more to testing sites. That's what we've been doing, more to the testing sites for the COVID, running them through, returning them back home that needs to go directly to testing versus taking them to the hospital. I do notice that has been some areas where behavioral health is one area that we've got a pilot going on right now to keep these behavioral health, because like you said, I think that is our next wave of calls that we're really going to see an increase on, not just people not calling 911. I think, there's sicker patients now because they're not wanting to go to the ED. Now you're seeing that nationally, but I think the second wave is the behavioral health piece that has just begun to scratch the surface.
How about some internal financial mitigation solutions during?
So that is probably one of the biggest questions that I'm getting a lot of questions is, what do we do? Of course, we can't wait on the feds. The feds take forever. By the time they pass a stimulus bill, by the time the funds even start flowing, it's taking weeks and weeks and weeks for that to happen. So as a ambulance service, what are you doing on the local level? I don't care if you're governmental to private to nonprofit. It doesn't really matter what your organizational type is. You have got to coalesce around a message on the state level. And quick funding right now is to focus on your Medicaid reimbursement and your uncompensated care at this point in time in your jurisdictions. As people become unemployed, what is your state? If you're in an expansion state that's expanded Medicaid, are they going to allow those people to come onto the rolls? They're going to have to make some changes and decisions to do that. There's ways that they can use some of this funding that's in that stimulus to help. And it's the reason why probably I've been doing a lot of webinars related to this, because reimbursement is my area of expertise, and you've got to get outside the box. If you think narrowly like this, well, all I can go after is tax funds. All I can go after, and our tax revenues are decreasing because people aren't spending money. So what other avenues do I have the ability to go after? Now is the time to reach out to your other EMS entities, whether they're your competitors or not, or what. You need to kind of say, we got to do kumbaya here, folks, but there are ways to get quick funding to at least begin to bridge the gap. To narrow the delta a bit. That is important, and Medicaid and uncompensated care are where you need to go right now pretty quickly. FEMA is another area. A lot of people have had concerns. It is not just related to governmental entities and nonprofits. For-profits can be involved. You just have to get creative. There's a different avenue you have to go through to get access to FEMA dollars. But remember, FEMA is payer of last resort. That's key for people to realize.
So what's going to happen with the edict about no balance billing? When do you think that'll end?
So that has probably been one of the issues in our industry of misinformation. So there was some information that was put on a website that if people would have looked at the T&C or the actual terms and conditions. Sorry, I've been talking all day today that I'm all my acronyms and trying to make sure not everybody knows what the acronyms are. But the terms and conditions of that basically it was only for presumptive COVID patients and positive COVID patients. And we are doing some data right now as we are working on the data to look at the uninsured. We're working on an initiative for the third tranche of funding right now, but we are seeing that it is a very small percentage of the numbers that would be equated to that T&C. It is not all of the transports that you do. It is only relative to those who are presumptive or positive. And that is what the T&C states and has been amended to say that was their intention from day one. So unfortunately, there's been a lot of misinformation out there, and I'm concerned that some people didn't take that first tranche of funding because of that and because of that misinformation.
Do you think that any of the legislators are finally going to understand that we haven't been being reimbursed what we should have been reimbursed all along? Because I mean, there are services that are going to go out of business because they were barely getting along before. Now they've had to lay off transport crews. Now their emergency call volume's down. They still have the same overhead and costs. And going out to shoot, we were not getting what we should get to begin with. How do we
So
solve
I'm the
that?
proverbial optimist. Yeah, so I'm the proverbial optimist, AJ, but here is something that I've been on numerous calls and just this morning with another coalition group. And I basically said, for too long, this industry has allowed others to advocate for them. I'm not taking the responsibility. I will use my voice
Yeah.
to advocate. I will use it, but it's just like if you are drowning, are you going to be yelling and looking for everybody to help you get your message out? Or are you just going to sit there and go underwater and eventually drown? Because if you're relying on me to be your only voice, then unfortunately, you probably deserve to go out of business. I'm not trying to be mean about it at this point in time, but
Yeah.
if you're in dire straits, it's like we have said at our company, this is our 911 call to you. You call 911 when you need us. We are now making a 911 call to you.
Yeah, and I've said this to many people. Any town hall meeting, you should be there in uniform, and you should be saying, "Whoa, you forgot about us. We had uncompensated funds to the tune of $150,000, and nobody even thought about us." The hospitals are laying off people. We're laying off people as well. So you can't just wait. There's like a line item category that got me that somebody put out there. Oh, we need PPE. That's ridiculous. We could get PPE. PPE is the smallest part of what I'm worried
My
about.
standpoint is you're not going to need PPE if you can't open your doors, if you can't pay your employees, and you cannot get your rigs running and go and picking up a patient. There will be no need for PPE. You've got this wrong, folks. I don't want to hear it again. I just got off another call saying, I'm not trying to be mean about this, but all this other stuff sounds really good from political talking points, and it sounds sexy and all that other kind of stuff. But PPE, private death benefits, hazard pay, anything else that you're talking about, if you can't keep your employees employed, you can't keep your rigs running, you can't go pick up patients, none of that means a hill of beans. How much more direct do you want me to be, AJ?
Yeah, well, and even equipment-wise, I'm an advocate that every ALS unit should get funded for ventilators. If we had a ventilator on every ALS unit, we could have stripped some of our spares and given them to the hospitals when they didn't have enough. The reality is, and I've said this before, bag masking somebody in this day and age is the 70s. You go into the OR, and I used to go in to do my tubes. He'd put a bag mask on to give the patient some of the gas. And then as soon as the patient was out, they were on a ventilator. And Oklahoma City and who else was I talking to? Tulsa. They've been using ventilators for 10 years. And there's no reason. If we went out now and said we need ventilators for all of our ALS units, they're making so many damn ventilators, they're not going to know what to do with them. Everybody cried, they needed this, they needed that. Like the task force says, they don't know of people that have not gotten a ventilator to point. And if that's the case, and they got GE and they've got Ford and everybody making these thousands of ventilators, give me some free.
I will tell you this is where I think there's going to be a big change that the industry needs to prepare for, is more oversight. I was on a phone call last Thursday with the chair of one of our states' Health and Human Services, and the very words out of her mouth was, we are never going to let this happen in the healthcare industry again. Mm-hmm. There are things that we assumed the healthcare industry had. They were specifically talking about the nursing homes at this point in time,
right,
that we did not realize they did not have, lack of oversight. Patients are dying because of this, whatever, whether it's funding, they should have given more funding. But I do want to let the industry know, EMS is not only going to change from the reimbursement model of it, but expect there to be a lot more oversight. So when you do the after action reviews to figure out what more do you need, what could we have done better on, what are the funding, and you better have your data together. You better have your stuff together. If you've been operating an agency kind of willy-nilly skirting around the gray areas or what have you like that, this is going to change the industry in general, not just EMS, but healthcare, the oversight, the reason why we weren't ready, whether it was because the funding wasn't adequate, operationally it wasn't done correctly. But gone are those days. I agree with you. You're going to see in the next 2 to 3 years, the industry is just going to change in its totality.
So what about federal and state solutions? Do you see any to help bridge the financial delta?
I think so. Short-term and intermediary, your short-term plan needs to be focusing on your Health and Human Services Department right now. They can infuse funding into you like that if they wanted to. That is going to require a very concerted message. They can get the money to you faster than the feds can get it to you. They can make it more localized, whereas the feds formularies, remember, is looking at to disperse it in all 50 states and to try to do it as easily as possible and then in focused hotspot regions. But your state can make it much more locally driven. So in our short term, we've got several strategies going right now. You've got your federal strategy, you've got your state strategy, you've got your local strategy going. If you do not have 3 strategies going right now, you are way behind the 8 ball. And yes, you can just say, well, we're not an Acadian or we're not a larger company that has resources. What you do have is you can pull your people together. One thing that I've learned about the human spirit is if they want something bad enough, you will go do it. I can either be a doer or a whiner. You decide who you want to be. I'm not going to sit and whine and expect somebody to come save me. I'm going to be the one that goes out there and says, let's put an action plan together. Let's call somebody. I may not have the acumen, I may not have the resources or but I might have an acumen that I can bring to the table to help keep it concerted. That is, in my opinion, if you want to get something infused into you and you are on life support right now, with anything else, you can either say, I'm just going to die and move on out into the sunset, or I can say, you know what, I'm going to survive. Let me reach out, because there are people willing to help. As always, in any crisis, people come forward. That is the American spirit. We do that regardless. It's the reason why we're going into the front lines right now and treating COVID patients. It's the reason why we have many of our EMTs and paramedics who have been exposed, who have caught it. We've unfortunately had a few that their lives have been taken because of it. So we know how to rush to help. It's the same concept that you need to apply to your finances and to your sustainability. Same concept.
So give me 3 action items. What should everybody leave this broadcast and do?
One thing that I would say, the first thing is, and I'm going to go to the point that you made. The first thing is you need to make sure you've got a plan around your data. That's number 1. You can't get reimbursed for something that you are not itemizing and that you do not understand. That's your number 1 piece. Number 2 is you need to be engaged in your community on understanding the financial piece of this. Where can I go? Who can I go get help from? And you need to have a local, state, and federal strategy. That doesn't mean you have to own it or do it yourself. It just means to know what avenues do I need to go. And then the third thing is you need to begin looking long-term of what your agency is going to look like in the next 6 months to a year. And you need, if you don't understand what's been going on in the telehealth space and what these waivers are that they're doing, you need to begin to educate yourself, reach out to your national association. A lot of these individuals are keeping up with it, but the waivers that are being issued by the hundreds during this public health emergency is a window into the healthcare soul of where we're going. So if you're following the waivers, you can begin to see where the path forward is going.
Yeah, and I'm going to tell you, most people who know me, I'm a hound dog. And I'm going to tell you right now, if you're waiting for a once a month journal to come and tell you what the latest trend is, you're done. If you're going to an EMS conference just to hear about how to demobilize fractures, you're done. We are in a crisis mode. We're in a follow-up mode. If you're not documenting, let me tell you what, you know, if big organizations and the Celtics and people like that could get $50 billion and nobody knew that they were getting it, the accountability after this is going to be incredible. They're going to give us money, but they're going to expect us to be accountable for it. So you ask somebody,
these are most of these funds are grants.
Right.
And think about it like a grant. You got to have meticulous documentation. If you cannot prove it, they will take it back.
And the other point is, you got to ask the number of people who never talked to their health department. And all of a sudden, I did a show with the group from the Sacramento area. Their health department called them and said, could you take over testing? Could you go in and bring up units to go into the nursing homes? And within a week, they had care units, 5 care units between 5 fire departments, and they impacted over 300 nursing home patients. And guess what they found? They went in and tested people that were asymptomatic and found that they were COVID positive. So, you know, you got to reach out, man. You got to go beyond your doors. You can't just go in and close, like you said, the garage doors. If all you're doing is going in at night saying, how many calls did we have? You're done. You're done. I mean, the whole industry, EMS is totally going to be different. People that were saying, oh, ET3, we're going to roll up ET3. We're well beyond ET3. This pandemic was like a tsunami. It just put a wash over the top of all of us. But there were some of those waves that missed us, and you can't let people forget those waves that missed us. You got to go to your state representatives. You got to bring them and say, did you know that one of my EMTs tested positive? And then we had to have 15 people that had matriculated with that person off shift for 14 days. And we had to backfill and pay overtime. And we had to pay those people and give them compensation, et cetera. There's so many tremendous things that are out there that I don't think the legislators or any of our legal people realize.
Make it personal. Tell your story to every local leader that has influence, because that mayor may know that state rep, that knows that chair of appropriations that now just got you funding. Never underestimate the power of your story. Get on a local media. I mean, we just came up with a talking point that we're educating all of the local individuals. Is there's over 500, the economic impact you have. You buy your insurance from the local insurance agent. You buy this, you buy, so you might think, oh, well, I only employ 50 people or 75 people. That's absolutely, but look at the economic engine you are in your community as well. So don't forget about that either. Tell your story, make it local.
And don't make it overly emotional, make it factual. Say, did you know? And they're going to be educated about it. You can't go in there and say, we need $100,000. Well, what do you need it for? Oh, to help pay our staff. Well, you bill. No, you don't understand. You know, we've been doing service for the past 5 years at a deficit, and nobody has paid any attention to that. Fix that. Fix reimbursement for us.
A lot of them don't even know that you do not get paid for every patient that you transport that doesn't have insurance. The majority of people, and I've been doing this for many, many years, and we've educated, they still act like they're surprised.
Yeah. Yeah. Like there's some little gift drone that comes and drops money on the top of us.
I guess we just go to the backyard and pick the dollars off the tree.
Well, listen, as we conclude here, I'm going to thank Asbel, and I'm going to make you a promise, just as Asbel is, and that is that we're not very quiet people. The new age, this is the new age. This is the new conversation period. For me and for GEMS, this is, talk to the people. I'm having somebody on. We're talking about prone positioning. I talked to some people the other day about prone positioning. Acadian and others are doing it. Oh, we can't do prone positioning on a stretcher. Why? You sleep on your belly. I've been reading through 250 pages of research, and prone positioning has a phenomenal effect right now on these patients. And I was on the call the other day with the Eagles when somebody said, why are we making a big deal about this? When a guy has a fracture, you splint it in position of comfort. When somebody is having trouble breathing, or if their pulse ox is down a little bit, let them get a little more comfortable. Hey, roll on your side. Let's see if we can get a change. Let's crank up your O2. Treat the patient, don't treat the protocol. So, we're going to be vocal about this. I appreciate you coming on today. And, I'll have you on again. Anytime you've got something to say, let me know and we'll put an episode up here. So for today and for myself and Asbel, thank you very much for being with us. And we'll catch you again on the other side.
Thanks, AJ. Have a good one.
Thank you.